시청자 여러분 안녕하세요.
Greetings, this is Prosthodontics on Friday, which looks at the different steps of prosthodontic treatment and addresses side effects in a very interesting way. Friday night Prosthodontics on Friday is back. Today, we're going to talk about restoring patients with attrition. This is the second lecture in its series. Let's welcome Dr. Park Hyung. Welcome. At the end of last year, you came here and provided a lecture on fixed implant prosthesis for fully edentulous patients, and thank you for appearing on our program once again. It is a very interesting topic. Before you begin, could you provide a brief explanation? My previous appearance, it was very interesting, and I'm honored to appear on this program once again. We're honored as well. Today, I'm going to talk about restoring attrition patients with implants and prosthesis. With increased longevity, and as people use their natural dentition longer, there are more patients with teeth wear, and prosthodontic treatment can be provided for these patients. When implant is used, it can be more effective. A lot of dentists hesitate how to treat wear patients, and I believe they'd be able to get a lot of their questions answered through your lecture. I look forward to your lecture. Those of you watching from dental site, on the right side, you can see there's a chat screen. You can use that to communicate real time, raise your questions, and these will be addressed. Those of you selected will be given Starbucks coffee coupon. I look forward to your participation, and let us begin Dr. Park's lecture. Greetings, I'm Dr. Park Hyung of Salt Ace Dental Clinic. In today's Prosthodontics on Friday, I'm going to talk about how to treat wear patients. I believe this is a hot topic which all of you are interested in. As the average age of the patients who visit our dental clinics increase, we are experiencing more patients with teeth wear. We have to restore patients with severe wear or attrition. This is a topic that I have keen interest in, and as you restore these patients, at first it may seem very difficult and tantamount, but with time, you'll learn to enjoy it as I did. Did you gain confidence? More than that, it's very rewarding and interesting. The downside is that if you focus on this topic, other areas may seem a bit dull. It's really interesting. I always try to stay on top of it as I perform my clinical practice. A person's dentition becomes complete in early teens, and we use it for the rest of our lives. The average life expectancy in Korea is over 80 these days, and you can see a lot of pathologic attrition these days. If you look at the level of attrition or wear on the occlusal surface, it's 30 micrometer per year. Therefore, if you use it for 60 years, it's going to be approximately 2 millimeters. I believe this research is quite true. There are not that many literature on treating attrition patients. I looked hard, but there are no researchers that really focus on this topic. In 2017, this is a consensus report, and it was of great help. It provides definition of attrition. It divides severe attrition and pathologic attrition. Severe attrition means that the dentin is exposed and over 1/3 of coronal area is lost. The prevalence is said to be 2%, but I think it's more common for Koreans. In the case of pathological attrition, what is important is age. Even if it is the same attrition, depending on age, it will determine whether it is pathologic or physiologic. Also, if there is pain that is experienced by the patient, we need to determine whether treatment may be necessary for pathologic attrition. When you come across a patient with severe teeth wear, whether it is physiologic or pathologic is very important in determining if and when treatment should be provided. Based on that, you need to decide whether you're going to provide treatment and extensive rehabilitation or observe. Today we're talking about attrition and wear. There are more cases where posterior area is lost rather than only the interior being grinded off, with posterior area intact. I believe that loss of posterior vertical support is one of the most important factors in causing occlusal collapse due to attrition. If you look at these cases, there's no posterior support, or it is class 1 RPD, Kennedy class 1 2 RPD. As posterior support is lost, excessive force is applied in the anterior area, and attrition and wear occurs in the anterior area, exacerbating occlusal collapse. This is a vicious cycle that can be observed. In the first image, crossbite has been formed. The second, deep bite. Third, deep bite. And the final is edge-to-edge bite. You can see different instances, and I believe that it may vary depending on the patient and the posterior factors. I want to ask you a question. When we provide full denture, wear can occur with decreased vertical height, and there can be class 3 tendency as the lower rotates. Does this phenomena also occur in natural dentition? I find this topic also very interesting, and I've looked at many literature, but there's no literature saying that natural dentition turns into class 3 if there's occlusal collapse. I made an image regarding this. Let me share this with you. This is not verified academically. It's just my theory. So it's your theory, yes. Unlike human teeth, if you look at that of carnivore or herbivore, ramus is short and lower body is very long as shown in the image. The horizontal vertical height of the anterior area and the height of condyle is almost the same. Think of an alligator. It opens and closes mouth like this. One of the traits is that as it opens its mouth, it's the same with increasing VD. There's no positional change in the lower, and it opens like this. Unlike these animals, in human, ramus is very long. The condyle is much higher than the occlusal plane or lower anterior. So when the patient opens or closes mouth, there's horizontal change in the lower anterior. I made this image based on the cephalometric radiograph. If the mouth opens by 5 mm without translation with just a hinge movement, and if you raise it, the lower anterior retracts by 2 mm. This is a rough idea, and just think of it as that there's a tendency. So if there's a wear, it goes forward. As wear occurs in full denture, the full denture occlusion becomes crossbite or edge-to-edge bite. And as I provide full denture treatment, if you consider long-term results, I find this as a format without a vertical support, and it's very difficult to solve problems related to anterior wear. Thank you for your answer. Let's look at some of the comments that have been raised in the chat screen. ID Watermelon Juice. Dr. Park, I hope you provide many more lectures. I believe this person is Dr. Park's fan. Dr. Park, you look dashing as always. There are no questions as of yet. We will address the questions later. Dr. Park, please carry on. In 4 cases that I've shown you before, if the patient's occlusion is crossbite, when a crossbite patient comes in, you need to consider whether the patient was originally crossbite due to skeletal or occlusal reason, or became crossbite as a vertical dimension loss occurred and the lower protracted. Anterior occlusion is very important in full mouth restoration. We need to make it into a class 1 occlusion. You need to consider whether it is possible. You need to think of whether vertical dimension needs to be increased or another method should be chosen. Thank you. In the images I've shown you, in the case of edge-to-edge bite, the contents that I've mentioned thus far is related to wear. And if there's wear, you assume that there is loss in vertical dimension as you provide treatment. In older patients, you can see at times that the anterior area has been fully grinded off and has become edge-to-edge bite, as shown here. In the past, I didn't give it much of a thought, but I came to realize that originally the patient had normal occlusion, but because of wear or loss in vertical dimension, the lower advanced forward and led to this result. On the other hand, as shown on the left, as you restore edge-to-edge bite, it's going to be very difficult if you don't raise the vertical dimension. If you try to protract the upper, it's going to be more difficult. If you increase the occlusal height, the lower anterior will be retracted and the upper anterior will be protracted, restoring normal occlusion. This is quite easy, and I'm sure most of you understand this already. I'm going to show you one of my cases. It's been approximately 17 years at the time. The patient was in her 40s. The lower is fully restored and posterior implant was placed right before image was taken. There's a little bit of wear on the upper. From 2005 to 2018, if you look at the changes, there's no trouble periodontally, but wear is occurring in a very quick speed. but it's difficult to know whether occlusal height has been lost. There's extrusion in the adjacent teeth and there's movement in lower position. You cannot know for sure whether there's a loss in vertical dimension, but occlusal height needs to be increased for aesthetic and other purposes. Can I step in? In 2011, 2018, so image was taken every 6 to 7 years. It's very difficult to have such follow-up images, and I thank you for that. If you look over here, the diastema seems to be increasing. Among the patients, some may have complained about this. They may feel more concerned about the increased diastema, saying that with age, the gap seems to be widening. Aging and teeth wear. Does it affect diastema in the anterior area? What's your opinion on that? A lot of patients become more aesthetically sensitive if diastema is increased in the anterior area. If you look at this patient, over the last 17 years, the anterior diastema has increased. But if you look at this patient, there's barely any mobility in teeth, and I don't think the teeth has moved. Due to worsened attrition in the anterior area, the central incisors are now in the shape of triangle. The incisal surface has worn out and the mesiodistal width has reduced and interdental papilla has been atrophied a little bit. The patient came to have full restoration, and one of the reasons was because of increased diastema. This may have resulted due to collapse in posterior occlusion, and due to overload in the anterior area, flaring can occur. I think it's quite different from periodontal or attrition-related issues. Personally, the occlusal force is towards the anterior. I think the occlusal force may have also caused this situation. So there are some literatures on orthodontics, and because the teeth are more proclined compared to occlusal plane, if masticatory force is applied, the mesial horizontal vector occurs, leading to increased diastema in the anterior area. Thank you. Now I'm going to move on to my patient again. I was continuing to observe this patient. Teeth wear occurred quite swiftly, and I told the patient that full rehabilitation may be needed. And I told the patient that she can have this restoration when the need arises. The patient came to my dental clinic because the diastema in the upper anterior was increased, and the patient just wanted to treat the two central incisors, and because there was no space, I prepped the lower anterior prosthesis and forcefully made some space to do restoration. After that, the patient's focus shifted to the lower, and the patient wanted the lower 6 anteriors. I told the patient that lower 6 anterior are not just what needs to be treated, and full rehabilitation may be needed in the lower. The patient agreed, and we proceeded with the treatment. I've talked about this in the literature consensus report, but we need to consider whether the patient's occlusion is pathologic. I believe it is so because the patient was in mid-50s and Then you need to determine whether you're going to increase vertical dimension or leave it as is and do other measures like crown lengthening. I thought it would be much better to increase the occlusal height, and I increased occlusal dimension and restored the lower first. When you increase vertical dimension, you need to think of the various situations. If the patient has a lot of natural dentition left, as is with this patient, and reduced VD, you don't know why the VD has been reduced, but it is necessary, so you need to increase it. Second is due to posterior area loss or periodontal disease or loss of teeth due to caries if normal VD cannot be maintained. Third, if the VD of the existing prosthesis is low and a restoration is necessary. Fourth is a fully edentulous or semi-fully edentulous. You need to form a new interarch relation and consider it as full denture. Let's look at the clinical process. So you need to make a diagnostic model. When you do mounting, you can just use the normal articulator. I've increased by 2 to 3 millimeter in the premolar area if there is more residual teeth. Increasing it too much can be stressful, so I just increased by the thickness of the prosthesis. The upper needs to be restored as well. If you want to increase overall by 5 millimeters, do half as you restore the lower and the rest as you do the upper. Provisional needs to be provided. In the past, you do wax up, copy, and fabricate it, but now I use CAD/CAM method. I use the original model. I use PMMA resin for milling. You use digital technology? Yes. I believe PMMA is an excellent material. I'm going to do final restoration using single crowns, but as for provisional, I segmented it and made it like this. If you look at the clinical process in the lower, I removed the anterior 6 prosthesis and formed the abutment, and I just prepped it in the anterior area so you can see the difference in the lower. After fabricating the lower anterior provisional, I fabricated provisional for the posterior area as well. On the implanted prosthesis, I roughened it a little bit and used composite resin to form a tentative posterior restoration. The patient adjusted to it very quickly. I'm going to skip through the specific restoration process. A final prosthesis was made with all zirconia. I did not do upper and lower at the same time, therefore, making left and right symmetrical and forming an ideal shape was a little bit difficult, but the patient adjusted to it extremely well and was satisfied, and I felt really rewarded. The crown abutment was very short, and the lower anterior crown failed once. After re-cementation, the patient has been wearing it for 2 years, but there has not been any major issue. This is before and after treatment. This is when the treatment was completed. The clinical crown was lengthened, and this led to increased aestheticness. And in the posterior retromolar area, the patient complained that her gum hurt when she bit, but that was mostly resolved as well. This is after 1 year. The patient adjusted to it nicely. This is after 1 year. The patient came and said she wanted upper restoration as well. I already had this in mind, and I used the same method I did with a lower, used the PMMA. After abutment was formed and temporary was fabricated, occlusal adjustment was done, but it took a lot of time. It took me almost the entire afternoon. I formed the abutment in the upper anterior and the VD was raised, temporary relining was done, occlusal adjustment was done. Abutment was not formed in the posterior area here. I left the posterior area alone so you can see how much the VD increased. I adjusted anterior guidance in the anterior area, and in the posterior area I formed abutment and the provisional was provided. I tried to make occlusal contact points for all teeth and did minimal prepping in the occlusal surface. The abutment was really short and the thickness necessary on the occlusal surface was sufficiently addressed with 2 mm of VD increase. This was how it was provided. In the upper, the patient adjusted well. This is the day when temporary prosthesis was provided. Aesthetically, there has been significant improvement. The final prosthesis was all single crown. On the anterior area, it was all zirconia crown, so transparency was slightly lacking, and this is possibly room for improvement. If you look at before and after, the increase in VD led to resolution of a lot of aesthetic and functional issues, and 2 years have passed and the patient is still satisfied. As for the upper, the crown has not failed as of yet. There are not that many cases where attrition occurred, even though there were a lot of residual teeth. It was of interest to me, so I did my best. If you take a look at the literature, in treating patients with severe teeth wear, you need to figure out the root cause first and then prioritize taking preventative measures. Another aspect in this literature says that once a prosthodontic patient, forever a prosthodontic patient, and delivery of prosthesis must be delayed as much as possible, and I agree. In moderate or severe attrition patients, if there's no functional or aesthetic problem, I think this is a very important point. If the patient is not aware of the problem, although from dentist's point of view, it may be quite serious, the patient may not feel any discomfort. If you make the patient participate in the treatment, the result may not be satisfactory, and treatment should be provided when the patient wants it. If possible, you need to preserve natural dentition and it needs to be minimally invasive. When you use composite resin, you can make a good restoration that can be used tentatively for a couple of years. You need to explain the options in treatment and prognosis to the patient well. The title of my lecture is Attrition, but rather than attrition, I've talked more about vertical dimension. When you raise VD, the treatment in teeth wear patients are more effective. The benefits of vertical dimension increase. You know that intuitively. You improve the tooth ratio aesthetically and improve occlusal relations in the anterior area, as well as other benefits exist. What we have learned is that as much as possible, we need to minimize change in vertical dimension. And changes in vertical dimension can lead to very serious side effects. But as shown in this literature, if you provide a fixed prosthesis with anatomical form, the patient can adjust to it really quickly. And that's also true based on my experience. Rather than using stent or appliance, if you provide PMMA crown with an anatomical form that does not fail easily. There are rarely cases where the patient becomes stressed. I believe changes in vertical dimension is not truly a taboo. You need to approach it cautiously. However, if you succeed in the increase in VD, then it's rather rewarding. Patients with TMJ problems, you need to pay more attention, yes. If the patient has unstable mandibular position or has lost teeth for a long time and mandibular position is unstable, you need to pay more attention. In increasing occlusal dimension, you need to wait 2 months and observe for the mandibular position to stabilize and for the patient to adjust. You said 2 months. Depending on the level of vertical dimension increase, the period where the patient uses temporary crown and adjust can increase or decrease. Is that right? On the literature, it says 2 months, but at times I provide fixed prosthesis more faster. If you do it only a little bit, you can provide immediately. Yes. Let's look at some questions. Let's look at the chat screen. Dr. Yong, thank you for the wonderful lecture. In attrition patients, when we provide implanted treatment, I always worry about occlusion. If you restore other areas as well, then cost will be an issue. How do you deal with the lateral force? It's a dilemma. In patients with severe teeth wear and with partial tooth loss, it's very difficult to form occlusion, and to provide full restoration from the patient's perspective, it's quite daunting. It's a very difficult question. The conditions need to be right. We need to provide explanation to the patient of where he or she is currently and how it can be treated. We need to provide full details of the treatment in regards to the treatment period and gain patient acceptance. If the patient agrees, we can proceed. If the patient doesn't, it's very difficult to move forward. Partial restoration. You can provide partial function, but laterwards, the patient may feel the necessity of full restoration. In that case, you'd have to do rework on what's been already provided. You've provided such a wonderful answer already. Yes, this is a question that we always deal with. Regarding lateral force, it's quite difficult to understand. In patients with severe teeth wear, if anterior guidance in the anterior area or disclusion in the posterior area is not done well, the implant may be overloaded. I think this is a practical question. In patients with severe attrition, at times in the posterior area, it's fully grinded off, and the natural dentition could become bilaterally balanced occlusion. The problem with these patients is that it's difficult to differentiate occlusal functional stop and interference. If you remove interference, then there's no vertical stop and the vicious cycle continues on. In the case of posterior area, if you provide insured PFM implant, The PFM fractures very frequently. These days, for patients with unclear anterior guidance or lateral guidance, I just provide metal occlusion. Aesthetically, it may be a little bit problematic, but I think this is a good compromise. Greetings, Professor Torino. You look awesome. Dr. Park Hyung, nice to meet you. I'll listen to your lecture avidly. When you raise bite, which tooth should be used as a basis? And the amount of raise, is that about the amount of thickness of the prosthesis to be fabricated? And what is the limit? The amount of raise, it's quite random. And in the literature, it says increase by the amount of what is necessary. In the case of posterior area, that'll be the thickness of the occlusal surface, and in the case of anterior upper, the amount needed for overbite, overjet, and for anterior guidance. In line with the set criteria, the limitation should be set. In severely destroyed patients, at times I raise by 10 to 15 millimeter, but the amount of raise itself is not very important. The patient with a severe situation, you need to raise drastically. As shown in the first case, if there's a lot of natural dentition, you need to raise minimally. If there's a lot of destruction and there's a few residual teeth, then it is more up to the dentist. Even if you make wax up, shell is not applied as is. During diagnostic wax up mounting, as for bite registration, do you do that following the amount that is going to be raised within the patient mouth, or do you use the anterior bite block and register CR bite mounted and do diagnostic wax up? Or do you use MI and mount it on the articulator and use incisal pin to do wax up? I think this has to do with when you fabricate prosthesis. I don't really use anterior bite block. I use MI and mount it and use a pin to adjust it. When you do full rehabilitation, you go through trial and error in terms of occlusion, and you need to utilize the temporary prosthesis, and with this you get the time to adjust it sufficiently. Just by using incisal pin, you can just rely on your instincts. Provisional restoration provides us a lot of help to us. It's easy to adjust. You need to make provisional restoration, and you need to do it properly. And if you adjust it in patient mouth properly, then there will be no major issues. There's another question by the same person. The CR posterior area is not actually a point, and when you raise VD, the position with rotation and three-dimensional position can be different, and having the patient adjust to it is a very difficult process. And in this case, rather than doing upper and lower at the same time, by doing the lower first, do you think you may have helped with the patient adjusting to it? I did not think about it, but I agree. If I had done upper and lower at the same time, it may have been more difficult. Lower would have been more difficult because the upper was natural dentition. I followed that and restored the lower. And that allowed the patient to adjust better. The position of mandible. This is in line with what I've already mentioned. If you put in due care in fabricating provisional, and if you use a PMMA and mill it, it has a very good durability. and it's very good for long-term use. When I attach provisional restoration, I don't use a temporary cement but use zinc phosphate. It's difficult to remove it, but there is less possibility of failure or fracture, so I use it. It is stable and strong, and aesthetically it's more stable. ID returned Mr. Lee. I think the program is much more lavish after it has got the renewal. Thank you. Our staff has worked hard to improve the setting, and that's why it looks more luxurious. ID, happy day. In doing full restoration, if you just restore using only full zirconia, the patients often complain of the loud noise upon occlusion. Do you have any solution to this? A lot of patients complain about this. There's a pounding sound and yes, as if it's hitting against something. At times, if there's a little bit of interference, a screechy sound can be heard. Zirconia has many benefits, but this is a major downside. The pounding noise itself. With time, patient adjusts to it. This is because the patient has not adjusted to the new vertical dimension and position of the mandible. And upon occlusion, the patient is unable to adjust the speed and force in doing occlusion. And with time, the patient can adjust to it. The interference, this can be an issue if left untouched. At the very least, interference needs to be removed so that the screechy sound does not come out upon lateral occlusion. When we tell the patient, this is an idea, but we can tell the patient that when you wear your sneakers and move on to dress shoes, it may feel awkward, but when you get accustomed to it, things will get better. Sneakers are definitely more comfortable, but dress shoes are also okay if you adjust to it. In regards to the rickety sound, you need to find the right occlusion. The pounding sound itself, it's okay, but the rickety sound, sliding centric or other problems can occur, so you need to find the right occlusion. Happy day. Professor Cho, Dr. Park, your voice tone is very nice and I love the way you talk. Thank you. As for the rest of the questions, we'll address them later and please carry on with your lecture. This is a second case. This was an elderly patient in late 70s. Vertical dimension is lost. There are not that many patients with severe attrition, even though there's a lot of residual teeth. Either there's no support in the posterior area or it is impossible to maintain class 1 RPD vertical support. You can often see distorted occlusal plane or deep bite. The patient had a class 1 IPD on. Overjet in the anterior area was sufficient, but attrition occurred and pulp was exposed. This is often observed in distal extension partial denture. Because the patient is unable to chew properly posteriorly and there's no proper stop, the patient intentionally pushes the mandible forward, leading to severe attrition and fracture in the anterior area. I mentioned that if you increase the lower vertical dimension, the anterior, upper, and lower positional relations change. If you look at the image, this is also included in Dr. Dawson's textbook. If the posterior area is lost or if attrition is severe, the anterior area can be edge-to-edge bite, cross-bite, or deep bite. You cannot anticipate how the mandible is going to respond. The patient's original occlusion, or think of it like a game of tug of war. If one side between upper and lower starts to fail, where on dentin is going to be concentrated there? If the patient's anterior occlusal relation is destroyed, when you do vertical dimension increase, the lower anterior comparatively reclines. If the mandible is prognathic before restoration, then it will go to natural position. But in the last image, if it is a debite, if you increase VD, the lower will be retracted too much. If the patient is class 2 with retrognathic lower, and you increase the vertical dimension, then there will be no occlusion in the anterior area and open bite can exacerbate. And this can be quite difficult. Coming back to the patient, if you increase the lower anterior, originally it should be restored with a crown, but I used composite resin for build-up. So composite resin was used tentatively in the star martyr area, and the patient was quite old at the time. I wanted to take a more conservative approach and used composite resin. Did polishing and formed occlusal plane. When you provide extensive restoration before placing the implant, I adjust the occlusion and improve upon it. After that, you place the implant, and I placed the 2 implants in the posterior area each. Addressed the distorted occlusal plane with occlusal adjustment. The patient adjusted well to the restoration. The VD was raised, however, the patient was able to adjust within a fairly short period of time. I also wondered how long the composite resin buildup is going to last. It lasted longer than anticipated because implant provides a strong vertical support, and the load that was applied to the anterior side was distributed significantly. If I had provided removable prosthesis, I suspect it would not have lasted a couple of months. It's after 2.5 years. I wanted to follow up longer, but the patient is very old and could not make frequent visits. I heard that the patient was using it still nicely, although it's been 10 years. Doctor, generally, teeth wear patients, there can be many causes. They may have a stronger occlusal force, or the teeth may be weaker. There can be many issues. After treatment, if we are to provide full mouth rehabilitation, it's going to take a lot of time and a lot of money. It's not easy treating attrition patients. After treatment, do you provide special guidance to patients to keep in mind when they go home? Most of the patients are older, so you need to put it in plain words. It's expensive and the experience was quite tough, so you need to tell them to really take care of it. Basically, the patient will be able to eat whatever, but if possible, they should stay away from dried squid or other tough food. But you cannot overlook habits, and the patients sometimes come back with issues. Are there patients requiring night guard? Yes, I did provide night guard a couple of times, but I do have my suspicion whether the patient wears night guard properly, and I do have my doubts in terms of the effect. I don't really provide night guard frequently. I just do follow up, and if there's a occlusal issue, I just adjust the prosthesis or teeth. Please carry on with your lecture. As shown in this patient, if you provide vertical support using implant in the posterior area, you can get many benefits which were not available in the existing prosthesis. In the case of posterior or multiple missing teeth, if you place the implant nicely with good primary stability and do immediate loading, You can provide fixed prosthesis within a short period of time to a patient with collapsed occlusion. Also, you can maintain a vertical stop long term. You can extend the life of the anterior teeth, which are comparatively weaker. There are many difficulties in using implant for restoration. As mentioned earlier, there can be weird noises, and those phenomena can be experienced when implant prosthesis is provided in the upper. Unlike the natural dentition, you don't get the sensory feedback, so the patient moves freely and can have difficulty in adjusting the strength or speed. There's no periodontal ligament and there's no cushioning. If it were in a car, there's no chauffeur. With time, patients adjust to it. When you provide extensive prosthesis to a patient, I provide explanation like this. At first, it may feel dull like a piece of wood, but with time, it will become so natural you'll forget that it's even there. If you provide implant prosthesis for anterior area, compared with natural dentition, the position and length of the tooth becomes different, and therefore patient may have difficulty in pronunciation. This is the final chapter. In restoring teeth with attrition, in most cases, implants are used to restore the situation. In order to protect the residual natural teeth and to gain strong vertical support in the posterior area, these are the real benefits of implant. Increasing the vertical dimension can help solve the issues related to tooth loss and attrition when they occur together. When you do this, minimal increase is recommended. When we provide a removable prosthesis for restoration, we rarely use the term VD raise. VD increase is mentioned when we provide fixed prosthesis. The reason being, in removable prosthesis, VD cannot be maintained stably long term. In that sense, implant plays a very important role in restoring teeth with attrition and in my clinical practice. This is the end of my lecture. Thank you so much for the wonderful lecture. I believe there are a couple of questions. ID High Teen. I have a question. Are there any issues in using zirconia for teeth worn out? I experience a lot of that as well. Teeth with attrition. The clinical crown is very short and it is very difficult to maintain. At times it can fail. And patients with worn out teeth, they have a strong masticatory force and clenching habit. And at times the zirconia can be fractured. It happens rarely, but it does. Thickness of the occlusal surface needs to be at least 2 mm. If it cannot be secured, non-precious metal can be a good alternative. Gold has ductility and malleability and can deform easily. Therefore, I prefer non-precious metal. For occlusal surface of patients with attrition, I believe non-precious metal is the best. I use a zirconia for aesthetic and other reasons. There's the issue of failure, and zirconia itself is quite accurate because it's made in CAD/CAM method, but if you look at the adaptability of the inner surface of crown and abutment, the cement gap is quite significant compared to what is made via cast. I believe the gap will be addressed significantly at the lab. There can be such issues. In those cases, partially you can use gold occlusal surface or non-precious metal. If you're going to restore the upper at the same time, you can use zirconia for the lower because it shows well, and can use a PFM occlusal surface for the upper. Thank you. ID Camel. From long-term perspective, what is the prognosis of attrition patients with full rehabilitation? The issues that can arise long-term have been mentioned. Fracture or failure of prosthesis. In the case of anterior area, there can be diastema due to teeth movement. Continuous attrition can occur, and additional restoration may be necessary. What is important is that the occlusal form of final prosthesis should be in balance with the patient. If you make a prosthesis based on principle, the prognosis is very good. At times, patients can mismanage. Prosthesis can fracture, and if you make the prosthesis in one piece, for full mouth restoration, at times you may need to remove everything. And segmenting may be more favorable. After the treatment is complete and the patient receives a prosthesis, well, of course, the dentist needs to have done a good job, but after the patient returns home, they need to maintain it properly. It's half and half. 50% is up to the dentist, and the rest is for the patient. And not that many dentists emphasize the importance of patient education. However, I believe that's not it. Because the patient has paid a lot of money and has spent a lot of time, we need to inform the patients what they should do back home. I agree. I entirely agree. ID Awesome. After I restored a short crown length with single crown, food impaction problem occurred, and then I moved on to bridge. So how can I prevent food impaction when I restore using single crowns? Food impaction. I normally restore using single crowns. Sometimes, if I believe the teeth is going to move, I at times tie it together. Food impaction occurs very frequently when the crown length is short. Let's think about the reason. Clinical crown is short and contact area is extremely short, so the food can easily get stuck there. If it is too short, you can tie 2 each, and if it is tied, the food won't be impacted as much and it can be a little helpful. If you tie 2 short crowns, leveraging effect can occur, leading to decementation. The failure rate compared to single crowns increase. It's a difficult problem. Although we may have tried to make the contact tight, for one reason or other, there can be food impaction, and dentists cannot help with the physiologic tooth migration. We need to provide thorough explanation. We need to explain that food impaction can occur, and we need to tell the patient to use the interdental brush or the floss to remove the food that has been impacted. We need to educate the patient, or else we just need to make a crown once again. That's all we can do. If you have provided extensive rehabilitation in single crowns, there's higher possibility of food impaction. We think that contact may have been made perfect, but because of physiological tooth movement, even within short period of time, tooth can move, or if the contact of the crowd is too tight, occlusal force can come into the play and it can cause it to part further. If occlusion is not optimized because of occlusal force, teeth can move. We need to do our best, but the problems that occur later are largely dependent on patient's care. Thank you. Thank you so much for the lecture. There have been many questions, and thank you for answering them all. I would like to express my gratitude. I would also like to extend my gratitude to those who have raised your questions. Starbucks coffee coupon will be sent. Prosthodontics on Friday real-time chatting event continues. Therefore, please participate in the next lecture as well and win your coffee coupons. Dr. Park, last but not least, is there any words of advice to our peers or the students who are watching prosthodontics on Friday and studying? As I mentioned earlier, treating patients with attrition and providing extensive rehabilitation, it can be difficult at first. You need to go through training and you need to teach yourself how to treat the patients. However, once you overcome the barrier, you escalate to the next level and it's really rewarding. The patients are really grateful for the treatment that you provide in these cases. You can provide great treatment and receive corresponding compliments as well as business success. After having learned from your lecture, I believe more people will be able to treat attrition patients with more confidence. Thank you for coming in despite your busy schedule, and I hope to see you in prosthodontics on Friday with another great lecture. Thank you everyone for watching Prosthodontics on Friday. Did you enjoy the seminar with Dr. Park Hee-woo? I believe this lecture was a great lecture in helping you get various tips on treating attrition patients with implant and general prosthesis. If you have further questions, please leave them and Dr. Park will answer them via replies. Next time, Professor Baek Jang-hyun of Gyeonggi Dental School Hospital will talk about screw loosening. Thank you for staying with us up until late. Thank you.